This is Dr. Jim Del Rosso,
dermatologist in Las Vegas, Nevada, and very involved with the American Acne and Rosacea Society. And I'm very happy to bring to you this Audiopearl today, where we're going to be talking to Joslyn Kirby, who is Associate Professor of Dermatology at Penn State Health in Hershey, Pennsylvania. And welcome, Joslyn.
Hi, thanks for letting me join you. So just as an introduction, I am a general dermatologist in Hershey, Pennsylvania, and after about 5 years of working in a great clinic with great people, I've had influences from Diane Thibotot, who is a past president of the AARS, and Andrea Zanglein, who's done some great work through the AARS. But after about 5 years, I kind of found I wanted to take a different approach, and I was happy taking care of my patients in the clinic, but I thought that there might be a way through research that I could have a greater maybe influence on more patients. And so after about 5 years, I went back to school and got my master's. And so a lot of the research that I've been doing lately has really been informed by my practice as a general dermatologist and the goal of really just reflecting on what I do and what I did and trying to find some efficiencies in it and in a little bit of a way sort of questioning the status quo, questioning what I did, was it always the best thing? So that's sort of been the bent to my research.
I think that's phenomenal because I think to myself that when I'm driving home after I spent the day in the clinic, is there something I could have done better? Is there some way I could have expressed something better to a patient or maybe thought through a case differently than I typically do? So I think we always have to reflect and not assume that what we're doing right now is the best way or the final way that we should do things. So give me some examples of some of the things you've come up with. I know you've had some publications related to acne that have to do with getting population-based data from studies that are out there, or maybe some other approaches that you had. Can you work through some of the examples?
Sure. So one of the studies that I was really affected by and my practice was affected by was isotretinoin monitoring. And so this came out of when I was a resident, I got labs on every patient every month, and I just kept getting back, normal labs or maybe slightly elevated, and then they'd come back normal the next month. And, it just felt routine, and I questioned it. And when I went to practice at Hershey, their practice was totally different. So I think one thing I learned was that there's a lot of variability from practice site to practice site, and I learned that I was very much influenced by the people that I practiced with, but I also wanted to be influenced by the data. And so we went back and we did a systematic review, and when we could, we did a meta-analysis. So that's where you take all the studies that really are measuring the same thing at the same point in time, using the same type of lab scale, and you combine the results all together. And so what we found was for most of the common lab tests, there might be peaks in that 6 or 8 week time window after starting isotretinoin, which we all sort of expect. But what we were also impressed with was later on in therapy at 20 weeks or so, there were very few patients where there was any kind of important change from the beginning of therapy at 6 or 8 weeks to later on in therapy. And so that really was written up. This whole idea was just written up by Andrea Zanglein and her group, really showing that our practice is catching a lot of people. We're taking care of them. We're not finding a lot of abnormal results. And the important thing is medicine is still not a cookbook. So we're not telling every provider only do 2 tests. We're saying start with 2, and then if you're worried about anything, if the patient seems high risk or if the result comes back abnormal, then maybe do another lab test. But don't necessarily feel like you have to do a lab test every month.
And the bottom line to me is, you're not telling clinicians that if for whatever reason they want to get lab tests on a given patient, by all means do that. The clinician's judgment is obviously going to be very important, and it's always going to be there for whatever reason. But did you get any subsets on patients where you may have identified some risk factors ahead of time, like maybe their weight or their family history of hyperlipidemia or anything like that, or just basically go across the board to everyone, regardless of any potential risk factors?
So I think that's a really great question because it highlights some of the limitations that we have to acknowledge as researchers when we do a study. So you ask really great questions, and unfortunately the data we collected in that study didn't have that granular amount of detail. So people, I always suggest look at every study and tear it apart. And if you hate my study, do a better one. That's wonderful. But what I couldn't do in this study was really control for some of those factors that might identify high-risk people.
And you're looking retrospectively at data that was collected in other studies. It's not something that, when you say study, that you designed prospectively. You're going back and looking at collections of data and trying to find the best similarities you can from the information that's out there. So if you did it prospectively, you may have put some of those things in there to look at. But retrospectively, you don't have a magic wand where you can find information that wasn't gleaned. So I'm getting from this that here's what I've gotten from it after reading it, after talking to some people about it, and then in my own practice. I always did them every month because that's the way we did it. I was trained when the drug first came out and doing it that way for 30 years, right? And so thinking about it, you get a lot of positives that turn out to mean nothing, that you're chasing, and you're like, why did I get this in the first place? That you have a perfectly healthy patient that doesn't have muscle pain and you have an elevated CK or something like that, and then next time it's normal or it's significantly less. And I'm wondering, why am I doing all these tests? So I've actually incorporated it where I probably do at least one less test, maybe two, over a 5 or 6 month course of the drug. And I'm happy to tell patients that don't like the idea of blood tests, and that may keep them from even going through the therapy, that if everything's okay, I'm going to reduce the blood testing to whatever I can and still feel that this is a safe treatment for you. And it's helped that conversation. A lot of patients don't like the blood tests, and some of them don't follow through with the treatment because they don't want to get stuck. And that keeps patients from getting a treatment that would benefit them. So I don't know if that makes sense, but I've already started to make some changes in my practice based on, what you published, because you did look at a large number of studies.
Yeah, absolutely. And you raised two really good points. One, which is fear of blood tests. And what's important to realize, and I didn't realize this until I looked into it further, is the peak of when people have needle phobia is during adolescence. It goes down as we age, so it's less common in adults, but importantly, still there. So if you're starting isotretinoin on somebody who's 30 or 40, they still may be very fearful of needles, but that's much more likely to happen in adolescence. And it's about 15% of adolescents who have a needle phobia. And the second really important point that you raised was the kind of, inertia that we all have about our practice and changing it. And, talking to patients about how they're in their 4th month maybe, and you were doing your typical practice and checking labs every month, and suddenly they're coming in the 5th month and you're saying, now you don't have to have blood work. And what we all sort of want to maintain is that relationship with our patients. And so one way that I approach a sudden change in my practice when I'm talking to my patients is my suggestion, blame it on the research. So I'll say, there was just this research that came out showing that people like you who've had these normal blood tests and are on a stable dose, you don't really need to have lab work, this month. How do you feel about that? So it's not saying I was wrong as a practitioner. It's saying, here's this new information. can we kind of discuss this as an option and how it might apply to you? So again, just blame it on the research.
I've actually handled that by not telling them they're going to need blood tests every month. We'll need to check blood tests during the treatment. Now, obviously, with pregnancy tests, you have to follow the pregnancy test guidelines. But when you're talking about lipids and blood counts, and I was just at a meeting where I talked about this to a group of dermatologists. And it's interesting when they start making comments, I never check the CBCs because that's never really been a big deal, or I've only looked at the lipids and nothing else. People are doing things differently every month. They're not necessarily looking at all the parameters. So
that's great.
So how would you summarize this before we get on to for the listener on what the suggested recommendation, not hard, fast recommendation, is for how to incorporate this information in their practice?
So my suggestion is to go forward with what Dr. Zangline just recently suggested in her study. And what we do is we get LFTs and lipids at baseline. We get them again after the second month of therapy, because our typical approach is to start most people on 40 milligrams for the first 30 days. At the end of the second 30 days, so after 60 days of therapy, they've been on 60 or 80 milligrams, whatever their maintenance dose is going to be. It's at the end of that first month of maintenance dose that we get their second round of LFTs and lipids. And Andrea actually just shared a paper with me showing that we might not need lipids. And so we're starting the conversation about, is this something we need to do regularly? Because a lot of people are doing it knowing that they're going to see changes, but they're looking for the really elevated triglycerides related to pancreatitis and worrying that could trigger pancreatitis. And there was just a paper that came out showing that a lot of the cases of pancreatitis for patients on isotretinoin were not at times when people had elevated triglycerides. So the idea that we're checking triglycerides in order to prevent that pancreatitis, it might not be in that patient with elevated triglycerides, and it's something we just still need to keep an eye out for. So there is also perhaps a future step to just checking LFTs.
Well, at the risk of not, at this point, confusing everyone, because new papers are coming out and they're making certain suggestions. People think, well, what the heck are we supposed to do now? Is it reasonable to say whatever parameters you feel are important? If it's just LFTs, fine. If it's LFTs and lipids, if it's CBC, LFTs and lipids, whatever that may be, you monitor after that first month when you put the patient on a starting dose, and then many of us will elevate it up from finishing the first month through the end of the second month. You check at that point, and then if everything is okay, you don't necessarily have to check monthly thereafter. You could do it one time or whatever you feel comfortable with, but you don't have to feel this reflex that every single month you have to get all those laboratory tests. Would you think that'd be reasonable at this point?
Absolutely.
Right. Because if maybe we have to this or maybe we have to don't after a new paper, leaves everybody wondering, well, what the heck am I supposed to do? So I think until we get the more definitive answers, it's good that we're questioning it, but maybe we don't need to do all the testing that we thought we were doing before, just reflexly out of habit, like you say, because it's true. That's what we do, right? Mm-hmm. So what about moving on to the next topic, where I'd like to find out from you what you tell residents or how you teach residents to approach patients that they're seeing for acne, that they're seeing for the first time, or they haven't come in a while, and you're really basically starting them all over again, but they may have had previous treatments. In that encounter, what you really want to focus on, because, these office visits could become very random. A lot of times there's a parent there that's intervening, and that goes back to the blood stick thing. Sometimes the adolescent doesn't even get a chance to say anything. You don't find out that they have a fear of needles until the nurse tells you later that it was brought up when you were already out of the room, because the adolescent doesn't even get a chance to talk when you have an overbearing parent. So what do you focus on to teach them the questions and how to best ask questions to find out what you need to know, and then to engender some confidence in the patient so they follow your program and they follow up with the future treatment? I know just run with it the best you can.
All right.
It's a big question, but just run with it the best.
And I think I'm going to say I'm always changing my practice based on, my experience with patients. So I would say if I could give advice and it comes from mistakes I've made, I would say I never walk in assuming that when somebody has acne on their face that they're there for acne, because I've definitely stepped in it before, saying, "Oh, are you here for your acne?" And they say, "No, I'm here for this mole on my shoulder." And then I have to backtrack. So I walk into every room and I say, "So what can I do for you today?" And then they can volunteer what they're worried about. If somebody has acne and I really sort of feel like it's my duty to talk to them about the management, I'll say, while I was looking at that mole on your shoulder, I noticed that you have, a little bit of a breakout here. Would you mind if I gave you some, suggestions for that? So that's my first one. Second one is when somebody comes in with acne, I usually ask them to rate, is today a good day, bad day, or average day? Because I want to try and adjust my decision-making about their treatment, not only based on what I see today, but I'll sort of adjust it up or down based on them saying, today is a really horrible day, and it actually looks pretty good, or it's a really horrible day, and I agree with them, and vice versa. So I think taking into account not just what they look like at that moment, but what they feel like it's been most recently. Next one is I'll have a lot of people, residents I work with, who might come out and say, my patient took doxycycline before. They said it didn't work. And then I've also learned by being in that position as a resident that I really need to explore not only did they take doxycycline, but what dose did they take? What duration did they take it for? How often did they actually take the medicine? So one of the best questions that I'll ask when people come in saying they failed a therapy is really just digging into when was it, how was it, were there issues that maybe decreased your sort of adherence to that medication. And then when people come back in to see me, I'll say, not did you use your adapalene, did you use your doxycycline, it's how did you use it? So it allows them to admit that maybe they weren't perfect and they didn't use it every day. It allows them to say, I didn't even pick it up, or I used it once a week. And so then I don't take and escalate therapy with the assumption they're actually doing everything that I told them to do last time. So really getting the details about their therapy and doing it in an open-ended way.
And one of the things I heard you say at a recent meeting was how you say to patients about the difference between expecting failure versus expecting success if they're compliant with what you're giving them and they're not having any problems with any side effects.
Yeah, so that's a great point. When I especially talk to people about isotretinoin, it's often I've mentioned it at a preceding visit, just sort of putting that in the mind, and then the parent or the patient goes out and maybe does a little research on it, and I want them to do that because I want to try and dispel any concerns or myths that they may have picked up. And so sometimes they'll come in and they'll say, well, how likely is this to work? Because they again have reservations in their mind already from reading online. And so a lot of times I'll say, this has an 80% chance that you're not going to need to ever take this medicine again. You're not going to need a second course of isotretinoin. And that's different than saying, when I give you this medicine, there's a 20% chance that you're going to need a second course. Giving the patient one statement or the other statement actually leads to sometimes very different behaviors, because if we give somebody the more positive statement, 80% that you're not going to need this medicine again, or maybe not anything, that's pretty attractive. When you sell the risk, which is there's a 20% chance that this medicine you'll need a second time or you'll need some kind of treatment, that often, even though they're mathematically equivalent statements, people don't react to them in the same way. And so the first statement to the same group of patients, you would have maybe 90% of them say, oh, absolutely, that sounds wonderful. Giving the same statement, 20% risk that they would need a second course, you might see that decision to treat drop way down, again, even though it's the same statement. And so I've now taken this approach of giving people sort of both sides of a risk, not only with acne, but with actinic keratoses, and we actually just published a paper on that as well. It's called choice framing. And so how you frame a statement, either as a positive or a negative, a risk or a benefit, really does influence people's decision-making, and it's just important for us as providers to take that into account.
Yeah, I think if you're engendering a sense that you have confidence in the treatment, patients pick up on that. If you're if you have the sense in how you're stating it that you're leaning more toward failure in what you're discussing, people pick up on that too. And I think that's extremely important. Even if it's not isotretinoin, what I try to do is tell them that, you give me 12 weeks of you really being consistent with what I'm asking you to use, and I'm giving you a capsule to take and 2 topical medications. We're talking about you being compliant with all 3 and everything I'm asking. You give me 12 weeks, and I can get you to this point, and I'll, it's not cure, but significantly better. We go through that to some degree, and the staff knows what to say, what to expect. That if I don't get you to where we're talking about by 12 weeks, we'll start all over again. And I go as far as to say there's no charge for that visit. And I think I've had 2 free visits since I've been doing that for over 10 years. Because I tell them, if you miss, then you have to give me more time. You miss a day, you've got to give me 3 more days. You have to be compliant unless you're having a problem, and you will be significantly improved. And I think, I'm not saying it's universally successful, and I don't have data to show that. I just think engendering the confidence, I see a lot more success by expressing things that way. Because if patients use their treatment, most of them do get significantly better. So I think that I got a lot out of you saying that, and I'm very careful about how I express it, and I am also making sure the staff does it the same way. So, Joslyn, do you have any last recommendations or anything that's popped in your head during the conversation that you would like the listeners to know based on some of your observations or studies that are out there or research you or your group has done?
My only advice is realize that change is hard. And I have changed my practice in many ways over the last few years, just doing research, looking at antibiotic duration and looking at isotretinoin. And I know that it was easier for me to make a change in my practice because I was the one doing the research. But I know that it's hard to change practice, and it is an inertia. But I guess if I could just give people the advice to, look in the mirror and say, change is hard. And once you realize that you're not going to be perfect at instituting that new practice, and maybe you don't do it for every patient, it's okay to make the change sort of incrementally or to question it. But to not change our practice is also not the right way to move forward because there really are advances being made every day. So just realize it's hard. It's going to be incremental. Again, it might not be every patient every day, but the change can be helpful.
And you're not alone. Everybody
Absolutely
is. And also, the fact that you're making a change doesn't mean that you were wrong before and that you're beating yourself up that you weren't doing it, quote, the right way. That's not true. It's just a matter of making changes as we get more experience or we get new information. So I think that's all very important. Joslyn, this has been excellent. I enjoy your work, the papers that I read. I enjoy the presentations, and I've certainly enjoyed this conversation, and I think our listeners are going to get a lot out of it. Thank you very much, and I appreciate your time today.
Thank you.